Um, we have shifted one last panel from room number 15 to room number 19. So we will have the panel discussion on care beyond medical management of TB, pulmonary rehabilitation and palliative care in this hall. For the session, I'd like to call upon the moderator, Dr. Meera Bhatia. Would also like to call upon the entire panelist, Dr. Mattoo sir from Central TB Division, um, Dr. Rajam Iyyer from Hinduja Hospital, Dr. Rajani Bhat from the Sparsh Hospital, Bangalore, Dr. Sanjeev Nair from the GMC Trivandrum, Dr. Vishal Bansal from Vallabhbhai Patel Chest Institute, and Dr. PM Ramesh from GHTM Tambaram. Meera, over to you.
Please settle down. We are starting. Thank you so much, dear panelists, for joining for this session. हाँ. So I'll start with a brief. As you know, that management of TB is beyond anti-TB drugs, and we require comprehensive care, including pulmonary rehab and palliative care. So this not only is crucial for improving the quality of life of patients, but also helps these patients recover fast. So my first question is to Mattoo sir. So how do you vision the program? In the program, these components are crucial to be involved, to be included. Yes.
Thank you, Dr. Meera, for asking this question. And I think this is the last panel of this meeting. And this has been a wonderful journey for 2 days that we are here, and the different topic has been touched upon and talked about. When we are dealing with this treatment of the tuberculosis in TB patients, yesterday there was one session on the adherence, and there is one TB a person survivor who was sitting among us, and he was saying that what they have observed during the treatment, that when healthcare providers are providing services, they are having just a treating tuberculosis, the human touch and the emotional aspect of those things are not touched by the doctors. They are either indifferent or attitude is very rude. So that emotional quotient and the a service delivery component is the area where the program need to work more. And when we are treating tuberculosis, it is not a disease, we are treating a human as such. So we have to take all aspects of the humanity with it. What we are seeing, that we are giving treatment for 6 months. If it is a MDR TB case, then the treatment may extend up to 2 years, or the 20 months nowadays the maximum period. And after that, usually we are not keeping the follow up of the things in between also, when the person might be having some other complications, other issues are there. So we need to focus on those areas also. So palliative and rehabilitative care means that we are treating a human in totality, not only tuberculosis. Like there might be some post treatment sequelae might be there, a lung damage, the lung function capacity might be damaged. We have to provide the rehabilitative services for the pulmonary care also. In post treatment also we are having some challenges where a person a lung function capacity may be affected, so we need to look into that aspect also. And then we have to provide the some many times they are having the survival issues are also there, so we have to provide some vocational help also. And if you want to see that how program is scaled up and has tried this thing, so we are having these component incorporated, but it is not a countrywide approach, it is in selective institute. To quote, we are having some of the panelists are from those institutions, like Tambaram is one institute where we are having pulmonary rehabilitative guidelines has been developed, and we are having this palliative care guidelines also. It is a pre-final draft is there. Then other than Tamram, there are some other institutes to name, like KGMU is one where pulmonary rehabilitation has been there. JJ Hospital in the Maharashtra it was there. And in Delhi, RBI PMT is an institute which is supporting in the pulmonary rehabilitation and in the development of the guidelines. So this is one area where program has much of the area where we need to do many things, and we have to scale up across the country. What is the good point that program recognize it and program is committed to make dent in this particular area, and we are looking the inputs and support from the partners. We are having some partners also sitting here, because many times the program has the limited resources also. So that is how we need some support from the partners and the CSR component, where we can have those leverages to develop this particular area and provide the services to the TB patients. Thank you. These are some of the comments from my side. Thank you.
Thank you so much, sir. A very valid point you have raised, that we should address and address the emotional and psychological support to all these patients. Very crucial and should be included in the TB treatment component. Sir, I would like to ask Dr. Vishal, how do you think it is important that is it crucial to start rehabilitation program as the patient has been started on ATT, or the patient completes its treatment and then then we follow that patient for rehabilitation?
Okay, good afternoon. Thank you, Meera, for inviting me for this panel discussion. Yes, yeah, it's very imperative that, as Dr. Mattoo just said, that we should treat the patient as a whole rather than the disease. So when the patient is started on ATT, when he is diagnosed, it's like a stigma, like, that he has been diagnosed as TB and he must be having some disability. That's why he has approached the physicians to get the diagnosis and the treatment. So once the treatment is initiated, and initially like when they are infective also, but at the same time you have to see that once the treatment started, that we have to start rehab from that time only. So once the physician has identified, started treatment, he should be referring to the rehab clinics, or if they have a facility, or maybe just counsel the patient itself that they should start with, they should do the breathing exercise. And once the treatment is progressing, and if it is simultaneously causing much disability, like because most of these patients will have not initially, but down the line they will have many fibrosis, cavitation, they will have emotional component, anxiety, depression, there will be early fatigue will also set in because there are nutritional deficiencies also. So it is better to start the rehab activity simultaneously when the ATT has started. And if the rehab program is available, the patient should, once after few months of treatment, he should be referred to the rehab center or clinic to get evaluated and be in the program, or do at the home whatever exercises, other things he has been given.
Oh, thank you, sir. So, Sanjeev, sir, I would like to know from you that as Dr. Vishal has mentioned, that it should be started and the patient also should be started on these services as soon as ATT is started. So, what are the challenges to start these services at a PHC level, at a rural level? How do we do there?
Yeah, thank you. Thank you for that question. I totally agree with what was mentioned, that both rehabilitation and palliative care should be actually started as early as possible. Of course, there are challenges. I mean, patients are infectious. At that point of time, many of them are too sick to actually go through the process of rehabilitation and all that. So there are challenges practically in that. Uh, at the end of the day, we have like 25 lakh TB patients every year in India, and the number are so huge. On the other hand, the rehab models that we have generally, I mean, we have some experts here. So many of them are centralized. They are located in urban centers, and even those models can only take care of a small number of patients. The numbers that we have for TB are so large that it has to be decentralized, has to go down to the lower level. Now, the challenge at the lower level is that uh, our primary health centers, or even the taluk level hospitals, or even district hospitals, are often not equipped to do pulmonary rehabilitation. The dissemination of information about pulmonary rehabilitation does not go down to that level. Generally, pulmonary rehabilitation is known and the institutions are capable of doing rehabilitation only at tertiary care centers or at medical college level. So that is one of the limitations. So the demand probably should be there at a lower level, but so we do have models, like we have a model in Kerala called the Schwarz model, where we have tried to build in pulmonary rehabilitation as a component which can be delivered at primary care level. It's varied success. Some institutions do it, some institutions are not able to do it, but then I think that is a major challenge, because TB, our treatment is given at the primary health center or the PHI, and at that point where the patient goes, we should also give the other components of treatment. Rehab also includes nutrition and so many other things which is needed for TB patients, and I think we do have the differentiated care model, and we should identify those patients pretty early using the differentiated care model, where there are intervention to prevent mortality. Along with that, we could probably put in the rehab interventions also, to ensure that by the end of treatment or even after treatment, patient can live a very healthy and productive life.
So, like you mentioned, the SWASH program, sir, this is for COPD and asthma, if I'm not
Yeah,
wrong.
so
And how do you can you link them with the TB also
yeah, so
in the
if you
program?
go historically, I mean, the public health model for chronic respiratory diseases,
Yes.
the first model we had was a WHO model called the PAL model. That is a practical approach to lung health. And that particular model, the hypothesis was that a TB patient comes to a clinic. Generally, if you look at, for example, my state, Kerala, out of the presumptive TB, only around 5% turn out to be TB. Mhm. Our doctor asks for a smear exam. Nowadays, it's NAT. You ask for a NAT, and once the NAT is negative, they say you're okay and send the patient back. Whereas the patient came with cough, patient came with symptoms, we don't really address that well at various levels of care. So the hypothesis was that if you gave care for all respiratory symptoms of a patient, you will actually diagnose more of TB. So these are linked together. So then we came with the Schwarz model. Schwarz model was focusing more on COPD and asthma, but it's generally a model for all chronic respiratory diseases. And in the Schwarz itself, we have put in the NTEP, or then it was RNTCP diagnostic algorithm and all, because for your COPD, the commonest symptoms are chronic cough, sputum production, and dyspnea, which is often common with TB. So you need to pick up TB, and if at all you diagnose TB, you have to give care for TB also. So the linkages are there from the very beginning, and even in the vulnerability model that we have in Kerala, vulnerability screening model, COPD is one of our vulnerability factors. So there's a lot of mingling between the two. Of course, as of now, I think in Schwarz, an infectious TB patient would not be recruited for pulmonary rehabilitation because of the risk of infection and other things. But then I think post TB care definitely is part of Schwarz.
Thank you, sir. Uh, so, any researches or advances in the field of pulmonary? I'm like, it is open for anyone who wants to, like, if they are doing anything innovative in their center. Yes,
I
ma'am.
think I can share a little bit about a recent publication that's come out in primary care respiratory medicine. And this was a collaborative effort between the University of Hull, the Hull York Medical College in UK, and Karunashraya, which is the Bangalore Hospice Trust, and it has an education research arm as well, and Kasturba Medical College, along with a lot of inputs from patients, caregivers, and doctors taking care of people with chronic respiratory disease. So, what they've come up, what we've discovered in this study, is that there are simple, actionable things that can be used within the community. As Dr. Sanjeev Nair mentioned, most pulmonologists' view of pulmonary rehab is that it is done from a center where the patient has to go. Whereas there are a lot of breathlessness and symptom management measures which can be done at the home level by the family caregiver. So, this was about seeking inputs to see if one of the models which was developed in Cambridge could be something that can be used in India across primary care settings. So, I think the possibilities with that, with very simple education of how do you do breathlessness management using a handheld fan, all of these measures can be started at home, and it's not going to be as resource intensive as the TB workers educate families about all the other measures they must take. This is also another layer that can be added on. So this is the model for breathlessness is the breathing, thinking, functioning model. The paper that's come out is called Breathe India. It's just last week. And we had inputs from places like Basic Healthcare Services in Udaipur, which has a large rural tribal population with silicosis and tuberculosis that they take care of. So we had primary care doctors from there giving their inputs and challenges. You had patients from urban areas giving their challenges. So this is with the inputs from chronic respiratory disease patients, not specifically tuberculosis, but I think it is something, as Dr. Sanjeev Nair mentioned, when we address chronic respiratory diseases, we will include patients with tuberculosis as well. So those are the things that I think have promise for us in a programmatic level.
Definitely, this is a very good idea.
No, just to
Like
add to that, sir.
home-based
Yes.
rehabilitation can be tried. This is definitely would
Just to
like to.
add to this, I think the way we look at patients needs to change. We look at patients with disease, like this is COPD, this is asthma, this is TB, what they suffer with. So the health related suffering, for example, the distressing symptoms. If we approach patients from the distressing symptoms, for example, a post TB sequelae, his situation and a COPD situation is probably the same. But we really need to address via symptoms, and something like a breathlessness support service, like Rajani was talking about, which has come out of this paper, it really improves quality of life. And unfortunately, our patients who from TB who suffer are all in the young productive age group. So they really need to have a complete holistic look, because they are young, they probably have a young family, they have other needs in life, like want having to go for a vocation and raise children and probably look after elderly parents. So the entire psychosocial aspect of theirs can be supported by these kind of, by addressing symptoms. So not disease based, but addressing what they go through and what actually is changing their lives to improve their quality of life. That has to be the mantra, which is quality of life improvement. And if it can be
Thank
done
you,
at
ma'am.
home.
Yeah, thank you.
Yes.
I also know that something Dr. Vishal is also doing at his center, some innovation in pipeline, or maybe already started.
So just to add on, like like a few years back, we did a study in post TB sequelae patients, and it was a randomized trial, and we did a normal treatment, and we added rehab to another group, and we found that their functional capacity improved, and their quality of life also improved. We published that also. But what we found at that time was that getting them to the center was a major challenge, because patients, they had to travel a lot, and then they have to, because most of them are breadwinners, so they could not skip their day-to-day activity for the earning. So this time there is an ongoing study in which we are again randomize a group in which we are giving a supervised rehab program to post TB lung disease patients, and at the same time we have looking at the home-based rehab also, as Dr. Mattoo has said, that study is ongoing, in which we call all the patients when they come for the investigation, we assess them and then we randomize either to the home-based or to the supervised based. So now that is going on, and most of the participants have finished their program, and we just want to see whether if the home-based program can deliver equally effective, if we are able to improve their quality of life, improve their functional capacity, and as just mentioned that we're just telling them to do simple process at home. Only thing is we are giving them the concept, how to do the walking, how to do the exercise training, how to do the breathing exercise. So that is all we are looking. We are initially assessing them, and post pulmonary home based also we are reassessing them to just to find out and how they are doing it. And we do the follow up on through tele rehab also. That is one thing which is innovating, that to tele rehab we do the video call also to tell them if they're doing something wrong, then we can just correct them to do it.
Thank you, sir. Thank you.
Yes, ma'am.
Yes.
I won't say it is innovative, but it has been practiced in the GHTM Tambaram for a long years. As Mattoo sir told, it is a occasional rehabilitation. That is also, that aspect has been taken care by a GHTM Tambaram for a very long period. So those who have been treated and become a post TB lung disease. So we have a center for doing some government related project like bindings, printings, and wiring chairs, these types of works. So these patients are mostly are abandoned from the family, so they are staying, and we are providing the food as well as daily what is like daily wage per day. So it is a fixed set. So but it was initially started around 120 patients. Now even though patient has been reduced, So even these aspects can be extrapolated to home care post TB patients who cannot generate income for the family. So these aspects can be considered.
So you have also started palliative care department center at your institute. So you want to list some challenges in getting patients, or maybe infrastructure challenges, or resource challenges, or referral challenges, like anything, like after starting this department.
Yes, ma'am. We have initially started a palliative care for both DSTB as well as DRTB as well as like post TB lung disease. And even with the help of central TB divisions and union, we conducted one palliative care workshop also. Most of the members in this forum has presented there. And the first challenge we are facing is even though we are reading multiple models and referrals, the exact delineation to when to start the palliation treatment, and especially for DRTB patients. So even with the current regimens, we have a success rate of around 70 to 80%. What will happen to that remaining 20 to 30% of patients who failed all these regimens? So whether they can be shifted to palliative care, but what the at present the program is, we are keep on changing the drug regimens, whatever the remaining drugs left out, we keep on till the patient succumbs. So we have to take a decision point at what time we have to stop ATT and patient has to be shifted to palliative care. That decision, because in GHTM Tambaram it's a sanatorium concept. Most of the DRTB patients and who failed or relapsed, they are in the hospitals till they succumbs. So even though we are taking care of this medical aspect and nutritional aspect with the support from the CSR activities, we have these provisions also. And even we have a separate project like a wings of support. So where we are giving weekly once counseling sessions for the caregivers and the attenders and family members in the setting of under the tree. It is in the open space with the mosque with all infectious precautions, all these things. So we are giving counselings. And even at the counselings, if you explain the regarding the DRTB and its contagiousness, the next questions the patient attenders ask, will I will get infection in near future? So whether I can ask my patient to stay in home or keep it here till he become normal. So these are all the one aspects, ma'am. The other aspect still, even though we are a referral higher centers, the referral for the other comorbidities whenever they having other comorbidities. So even now the NMC has forgot about the pulmonary medicines for the UG course. So they even though allotted 8 seats in the 4 5 MDR TB wards, even the department is not there. How can they allot for that for TB patients? So even tertiary centers, the care for the DRTB is not um, up to the mark. Then how to extrapolate these? Even it's a sanatorium concept. We can able to adopt how many patients come. But in other peripheral hospitals and tertiary care hospitals, so there is definitely challenge in even keeping the patients, ma'am.
Thank
And
you, sir.
So,
Uh,
Dr. Mira, 2 points from my side over this discussion. Like one is with regard to the resources allocation for the palliative and the rehabilitative care. So, like when we are having this rehabilitative care in the at least tertiary care hospitals, this should not be much of issue. When we are having like a huge investment in the robotic surgery and those kind of where the crores of rupees are being spent in procurement and the government is approving those things. So like if you are saying the pulmonary rehabilitation care centers, you can compare the money involved in both, what is the ratio of those things, it will be very less if you are so first thing is that we need to when something is being proposed, we need to justify our demand, why we are demanding it. So this is one point. It should not be a big issue to have the resources available. It has to be your will, your justification for that, then definitely you will be able to do. Second thing is that it is a innovation research consortium summit is there. So we need to have the problem statement. Okay, how many of the pulmonary rehabilitative, like post treatment, during the treatment also, if research has to be done in this area, actually how many of patients the problem is there. government want to Government is willing to do the investment. They want to need that what is the quantum of the
Quantification.
problem. So research has to come in that area. Then we nowadays ICMR is very open. They are providing this some. They are saying that who is there from ICMR team? Somebody is here. They are saying that a digital mitra who is supporting the new innovations, how they can the platform provide, and somebody something is coming with the idea, then they will support. So HTA is one thing. They are providing health technology assessment. So if you are providing something justification, you can come and approach, and then if the cost effectiveness of the technology and the innovations may be approved by the ICMR, which is forward, then things will be approved by the bureaucrats, by the mantris, the fund will be allocated. And many times we are finding that health budget we are having, when we are providing to the state, usually most of the states are not able to consume the budget allotted. They are returning it to it. So resources, when we are saying the resources are limited, I think this is not a due justification why the rehabilitative and the pulmonary care has not been scaled up in the country. This is one point I want to highlight.
So you have answered. This was my last question to you. You have answered it without asking. नहीं, नहीं,
I
just
also need
complete
to
it.
just add a point, and it is one thing where we face very commonly about when to refer to palliative care, and just wanted to highlight that it's a very need-based science. It is when a person is not coping, it's irrespective of the diagnosis or the prognosis. But very often, I think the mindset is that palliative care should be at end of life, and that's one thing we want to really bust the myth, because if a person is not coping, that's when he needs that extra hand and that extra support. And so it can go parallelly with the treatment, and when the curative phase is kind of fading out is when we can actually offer more support. In that sense, what happens is that we are not treated as an alien member, that our doctor is now abandoning us and sending me to palliative care. If we walk hand in hand with the treating pulmonologist or the chest physicians, and they recognize us as a team member and realize that this person is going to focus on the symptomatic treatment for me, I know even if there is no cure. And I also think in tuberculosis, right from the time of diagnosis, especially when it's a bad TB, you need that extra supportive hand. When it's a drug resistant, multi drug resistant, managing the side effects of the symptoms of the drugs, the fact that he cannot go to work, the fact that the caregivers are not able to work. So there is so many aspects that palliative care can actually fill in the gap, so that the people who are treating TB focus on that, and the patient and the caregivers feel the support. And we are the friend during the journey, so that like the survivor said yesterday, we really need to see the human being, like sir mentioned. We forget that we see the disease, we see the cavity, we see the sputum, we see the positivity, but what he is going through, what emotions he is going through, the fact that he cannot have any intimate relationship with his partner, there's so much happening in his life that we completely fail to ignore, and we never ask the patient whether he's coping or whether he's okay. So I think all those things are small things, but when we become patients or when we are sitting at the other end, we realize it makes such a big difference when the doctor is listening to us, so that makes a difference.
True. Rajni ma'am, I want to ask, like, I've seen a lot of TB professionals, they lack the knowledge and skill what a palliative care personnel may be having. So, do you think that that gap should also be filled? The skills they should also be they should have that knowledge,
I think that's a
expertise.
huge gap across the board, across all specialties. Palliative medicine in India has been around for a very long time. We just had the 32nd annual meeting of the Indian Association of Palliative Care. But it came into its own as a postgraduate specialty only since 2011-12 when an MD palliative medicine came up. We now have DNB courses, we have fellowships. There are very few people you'll find who will be like Dr. Rajam Iyyer and myself, who are pulmonology and palliative medicine trained. There are very few palliative medicine doctors across India to address the palliative care needs of the general patient population, if we were to see. So I think the answer lies in bridging the gap by making sure that the basics of a palliative medicine approach are taught at every level of medical education. So since 2018, when you had the attitude, ethics, communication part, communication skills are part of MBBS training. But I think we need to reinforce it at every postgraduate level. Dr. Rajam and I have been part of a nice initiative which is about basics of palliative medicine for pulmonologists, and it's a 7 to 8 week program run with Pallium, where we familiarize them with symptom management and addressing the psychosocial, spiritual, existential pain beyond the physical pain and symptom management. The other big challenge, I think, is the fact that most doctors are in India are not comfortable with dispensing opioids and availability of opioids. Um, Opioids are restricted. There's a lot of worry and fear that doctors have. So these courses that we offer, trainings that we offer, are to help people get familiar with it is safe to prescribe low dose morphine for patients with breathlessness. The doses we need for breathlessness management will not reach any level of toxicity and will actually help the patients a lot. So that's one area that I think we can incorporate. um, while a lot is being done in the national programs with MBBS and MD and everything else, what is already there, we can layer on the palliative medicine approach. So I think there are programs in other areas where we've started doing that. For example, a 10-bed ICU initiative across the country, which is to strengthen ICU training, now incorporates in their 5-day training module half a day, which is 3 hours of an afternoon dedicated to integrating palliative care into ICUs. So, all specialties and all areas, we will have to start incorporating the palliative medicine approach because we will never have enough palliative medicine doctors for all of India.
And with opioids, I think the misuse and how to use both is an issue with the doctors. What I feel, the pulmonologist even they don't know what is the dosage and what which patient would require this more, and it is given to whom.
But that
That
also comes to training, right? We are
training,
not
yeah.
trained about opioids. Second thing, we have seen the way the West has gone, and so we've got scared. The idea is to learn from that and not go that way. Having said the fact that we produce the maximum of opioids in the country, but still the quality of death index in India is so poor that Indians are dying with suffering. And we really need to focus on why we have become doctors. It is to mitigate suffering, right? And it's not to cure always. We are not the Lord to cure everything. We really need to mitigate suffering. And the suffering is not, it's obviously physical, but it's way beyond that. Physical is what we see, but what we don't see is what palliative care wants to offer a hand to help. And that is very important because we are dying poorly in India. And despite the fact that Sir pointed out, robotic surgeries ho rahi hain, but people are dying poorly. I mean, where's the connection? So, we really need to focus on why we have become doctors and what we can offer as healthcare professionals. Because finally, we are healthcare professionals and we have forgotten to care for our patients. I really feel that very
If I may,
strongly.
I'll just add one little point here. I think this lack of palliative care and access to palliative care is being addressed at the national level. Um, so the NHSRC, for example, we've come up with training modules for primary health center doctors as well as nurses and community health workers to detect distress and suffering, like when patients with any condition. So you might be a community health worker, but if you're going through, like I said, all these trainings will get incorporated to every level. If you're able to detect that this person's symptom burden is high, this family's care needs are high, then you can elevate it. And the hope, of course, and the goal is that every PHC should be able to offer basic primary palliative care support to any of the patients in the national TB program as well.
Actually, with opioid, there is some regulations. We all know these are the habit forming substances, and like there is one simple the example is the Corex syrup that has been misused by the others. So usually these are the habit forming substances. These are very good, like in the cough also relieving and those things. Breathlessness, opioids are they're great. This is one thing, and that is why government is having regulation to control these things. There is one example like Dr. Bansal must be remembering, and it was from over time during the graduation only MBBS time. The misuse was there. There was one injectable was there, and there was one I think uh, some clinic was there for the beautification, and in that it was a famous case. I will not reveal much of the things, and injectable were used, and then it led to death also of that particular. So it is like many complications are there. So government is having some regulation issues are also there with these opioid substances, and that is why these medical professionals are also scared to use those things. The accessibility to whom the drugs may be kept, the nurses under locker, those issues are associated with those things. Yeah.
Thank you, sir. Rajam, ma'am, I want to ask you: Is there any models of integration of palliative care into the TB program, mainstream TB program?
So, we are still trying to create. Like I said, I really think we need to focus on the needs of our TB patients. It's completely need based. Palliative care is need based. So, it's irrespective of the diagnosis, whether it's TB, COPD, asthma, cancer, etc. It is the patient suffering. So, as of now, we don't have any ready models. But to be honest with you, the earlier, like Dr. Nair said, the earlier we integrate palliative care, when you earlier you identify distress, like Rajani mentioned, or a patient not coping, you really need to think of integrating palliative care. And it's not rocket science. Like Dr. Rajgopal always says, it is high touch, low tech. And that's what we really need to incorporate. Like, we can never think of having a hospital without an emergency department. In the future, we really need to think of having palliative care departments in every hospital, because there is a lot of suffering which goes unaddressed. And that goes the same with TB. It's a lot of social stigma, a lot of people unable to earn a living, continue to be in a married life, even post TB sequelae. There is so much spectrum in tuberculosis that can be integrated with palliative care. And I really think it's one of those abstract innovations which I'm really glad that both Rajni and me are part of this, because we were a complete misfit otherwise. And I'm glad that both ICMR and the union realized the importance of including palliative care in the 1.5 day summit, for which we are grateful. Because I don't think you can see palliative care, I think you can only feel palliative care. And I think tuberculosis definitely needs that integration.
If I may just, there's probably not enough models in India, but there are models in international tuberculosis national programs. So we have South Africa leads the way in integrated palliative care along with tuberculosis programs. There are programs in Eastern Europe where there's home based, community based integrated palliative care, specifically for drug resistant TB patients. Very challenging. Um, and it actually, these programs are where we probably need to take our cues from on the ethical concern that comes up about offering palliative medicine to technically an infectious disease, which is considered to be curable, or when do we limit the use of antibiotics with a concern for worsening the drug resistance problem that we have. There are models that we can follow, and it will, while these models exist, it is very essential that we look at create models in India, because our socio-cultural context is different. The challenges will be different. For example, the South Africa model is mainly an HIV and TB palliative medicine combination that's there. So we'll have to start these programs, and that's why I really appreciate the fact that we're making a beginning and having that discussion on a platform like this, where we will start devising those modules, the models, and then hopefully take that to the national level.
Thank you so much. Thank you. Really, it was very interesting. Yes,
Yeah,
sir.
yeah. Actually, we are having the national program for the palliative care. We have to have the integration with that, and Dr. Rajani and Dr. Iyyer are there. Until unless, because when we are seeing that home-based rehabilitation services and the model for implementation, if we are not involving over a peripheral health institutions medical officers trained in this palliative care, the things will not be easy. If we are just looking for a tertiary care institutions, only pulmonologists should provide this rehabilitative and palliative care, then things will not be feasible. We have to go to the peripheral level and a community level also. I will say that we need to train some our community influencers, ASA workers. We are involving them. The things will be difficult and the services will not be fulfilled and provided in a complete manner. This is one where we have to have this approach. The program is there, but I don't know, like if training of the PHC medical officer for that has been done or not. How much is there? If you can put some
So in
light into this.
Maharashtra, where I have been working, we've had regular training programs held in the by for the government district hospitals, and I'm sure Dr. Nair will tell about
Yeah,
Kerala
yeah.
too. Just one point before that is this fact that when we have home-based palliative care for other diseases, in fact, we also need to train our palliative care physicians about tuberculosis. So it works both ways because they need to know whether they're safe entering the house, what happens, etc. But home there in Maharashtra, we've had regular training programs for government PHC district level hospitals on palliative care, given them the modules and given them the steps of both non-pharmacological and pharmacological management of distressing symptoms. So that is happening on a regular basis. I'm sure Dr.
Yeah, I
Nair
think,
has.
sir, in Kerala, palliative care has rolled down all the way to Panchayati Raj institution level. So the Panchayati Raj institutions in Kerala have a big budget, bigger than what we can get from the health department, and, those budgets actually cover for palliative care. They have to keep a certain percentage of their budget separately. All panchayats have to keep a percentage of their budget for palliative care. So that is there. Now you are also aware that Kerala has a very good model of Panchayati Raj involvement in TB. So both of them are happening. The block there is that the Panchayati Raj palliative care team believes that palliative care is for malignancy and bedridden patients. The Panchayati Raj TB people, they believe that you provide nutrition to TB patients, occupational rehabilitation. They are not aware that you are supposed to provide rehabilitation and palliative care. So I think the block is there. We need to create more awareness at our level, and if that is done, the same people are doing the same work. So you just have to get them that these can be mashed together. I think that is a block that has to be overcome.
Thank you so much. Thank you. It was really interesting and very informative. I think we have discussed the issues, challenges, also some good practices, some models which have worked in various centers. What? Ha. Yeah, we are open for questions. Yes.
We've been, I mean, very interesting session, I must appreciate. And, but regarding one very important aspect which was left behind was oxygen, home oxygen therapy. Once we are looking at palliative care, I would give that because that is sometimes one of the reasons we are unable to discharge the patient. Because and the other is obviously psychosocial support and I mean encouragement that everything is not lost, there is hope there. So I've seen miracles happening, patients where you think that this child or this patient is not going to progress in a better direction. There are miracles, and I've seen those they're coming out of their disease even, and he leading a comparatively fruitful life. So we need to constantly have interaction with the patient provider, so that medical aspect only we know what is left behind, but emotional vacuum what these patients they experience is one thing which is our moral responsibility to have a very productive life whatever is left behind. And we are also morally responsible. Probably the patient came late to us, so that is the reason that this XYZ patient did not improve all the way what was expected. So we are also morally bound in that manner.
So, madam, just to add one thing regarding the home oxygen therapy, that's what one thing is when we induct the patient in the rehab program, we assess their activity of daily living and the oxygen status during that. So we just I want to elicit whether they are desaturating during their day-to-day activity, and if they are, then we advise them to have a home oxygen therapy. And if they're not able to, so yeah, so
And
That's
the government has no program where they can be made available free. Because who has the capacity to buy such an
agreed.
expensive
Yeah.
machine?
So that is the main
Oxygen
problem. Yeah.
concentrator is not easy to buy.
And these patients can get frequently readmitted and actually tap the health resources. So you really need to find the cost benefit of providing these at home so that they don't come to hospital unnecessarily also.
And to your question, I think COVID has done us some good. So, we have lot of oxygen concentrators now. So in Kerala, the Panchayati Raj institutions, the palliative care teams, many of them have got oxygen concentrators with them, which they actually provide to patients. In Kerala also, Panchayati Raj institutions have some money. So the very poor patients, when we give them a certificate that they need oxygen, often the Panchayat through its funds also provides. So your point is very valid, but I'm talking of only a small proportion who get that. Not everybody gets it. So that is the issue. But there are certain solutions. That is, Dr.
No,
Sayadu
I
probably.
think there's even more. So, I'm sorry, I'm just going to continue with the oxygen point over here. uh, Kerala always ends up being a beacon of hope or models for others to follow. There's another part which Kerala does, which is patients who require oxygen as an oxygen concentrator or a non-invasive device even for post TB lung disease. If they have a letter from a government officer saying that it's essential, they get a benefit on their electricity bill as well, because these devices need electricity and that's going to raise your electricity bill, so you need a waiver on the electricity bill as well. So this is how far ahead we have to think. Every burden on the patient, affordability on every level we have to think.
Accessibility and affordability,
Okay.
both components have to be taken.
A very enlightening discussion. Request from the palliative care group is please have some modules because we have got lot of patients with COPD, asthma, bedridden, old patients. Now, if you specialists give us a module for health workers and primary care physicians in palliative care, that is the thing.
There are
And
talks about teaching respiratory medicines in specific
yeah,
and symptoms for palliative care physicians,
yes,
which is outside the purview, like a specialist palliative care. I mean,
yeah,
for managing you at home, for managing patients at home, it's
yeah,
very important that you are empowered with that
yeah.
knowledge. Yes, it
Again,
is in the
yeah,
process.
pulmonary rehab also for old patients. Thank you. That was great. And yeah,
Those guidelines they are already in the pipeline. They will be out soon. So you
thank you.
that's something we have under the leadership of Mattoo sir and all our experts. We will be, integrating that.
Yeah,
One more stop ahead.
modules,
So those
that too in the perspective of a patient for whom the quality of life is most important beyond that specialty based thing. Thank you, ma'am.
And please include children because children they have their specific
pediatric
needs.
also, sir. So thank you so much.
Can,
That was really
can I?
informative, and I'm really thankful. Any more
Yeah,
questions? Yeah.
no, actually, I've heard a lot of talk about a lot of discussion. What I still feel that is missing in Indian context, and that is how to train the doctors and clinicians immunologically, because immune modulation, or to say more precisely, immune conditioning of the TB patients, particularly MDR patients, the patient with the necrotizing symptoms, patient with a cavity, is really a big challenge in the treatment and eradication of the TB. So the immune conditioning program need to be initiated at the national level. For instances, I see very less research ongoing in this area, particularly where the mandate is to reprogram the foamy macrophages, right? And the foamy macrophages in the MDR patients is a major problem. They are the giant cells, and they resist antibiotics, they resist any other rehab strategy. So I think this area is need to be trigger for betterment of the TB patients, and it has a tremendous potential. Yeah.
So yeah. So one thing is like we have been regularly organizing training workshops for pulmonologists to sensitize them and to deliver how the pulmonary rehab program can be delivered. Second thing is when the patients are undergoing under the pulmonary rehab program, like you are correct that immunotherapy and immunomodulation needs to be done, but when they are in the rehab program, their immunity boosts up. So that improves their overall quality of life, functional capacity, and so one thing is there the immunomodulation does go, but it has not been properly researched. But there are instances where it has been the inflammatory markers go down post rehabilitation. So that is one
I
thing.
do agree with you, but I don't see many studies coming from Indian labs. That's where I
Yeah,
might
so we
come.
have published few studies in which we have
Yeah.
looked pre and post rehab inflammatory markers. That's why I'm telling you, a few interleukins and cytokines, there's a level come down, but we did not find significance because the number of subjects were less.
And there are
Sanjay.
certain dietary component which can condition the immune system perfectly, and they can help the patient to recover much strongly. For example, is sphingolipid that we are working on, the sphingolipid pathway. Yeah, thank you.
I think your points are valid, but I think
Yeah, we
we'll
can
discuss
discuss it
that in a later
later
forum.
also. Thank you so much. I would end the session now, and I would like to thank all the resource persons, all the experts, and the palliative care and the pulmonary rehab component will go hand in hand with other TB mainstream TB program. Thank you so much.
I request Dr. Meera to hand over the mementos to the panelists. So, followed by this, we are going to have a very brief concluding sessions, which may not last not more than for 10 minutes. We are going to have a concluding session now in this hall. Yeah, even though this was the last the last session, the scientific session of the India Innovation Summit is closing here. So let's have a group picture with them, right? Fine, great. Thank you so much. Thank you. So we are going to have a very brief concluding session, very brief concluding sessions. So we are not going to have a dais or anything for this concluding session at all, because in the innovation summit, everybody is equal. So everybody is, I mean, there is nobody called guest or VIPs or anybody in this one. Innovation summit means basically it's a summit, and everybody is basically contributing to the summit in one way or other. In this entire India Innovation Summit, Pioneering Solutions for Ending TB, we had lots and lots of innovators, right? We had seen lots of innovators coming in, lots of innovations coming in. That can be scaled up, that are in the proof of concept scale. So first thing I wanted to thank